Hi everyone, so thank you to the organisers for letting me talk today, and also thank you to my husband who's managing my 4 children that I've given gastro to, and apparently the golden retriever admirably in my absence. I don't really want to go home tonight, so let's talk about management, education, resources and teamwork. So the demographics of our hospital. So we're a tertiary 900-bedded hospital, and over the financial year of 2016 to 2017, we recorded 3,381 MERTs in our hospital, which were over 156 different clinical areas. As you can see from the picture below, and I'm sure in all of your hospitals, it's over a huge geographic area, so coordinating the right people to the right place can be challenging. We get a median of 9 triggers per 24 hours, but that can be anything from 2 to 24. And simultaneous MERTs can happen at any time of the day, despite numbers of doctors in the hospital obviously changing. So what were the challenges that we specifically faced? So at an individual level, issues with resilience and self-care, issues with role identification and responsibilities. Did we have an optimal work environment for these people to function? Did they have appropriate education? Did they have appropriate feedback? From an institutional level, were we providing good quality care to a lot of patients with complex clinical needs? Was the demand on our system manageable? And did staff have engagement and feedback in the system that we were providing? And from a national level, were we implementing the new college requirements in terms of minimum responses? And were we meeting national standards frameworks for delivery of quality and timely care through the rapid response system that we had? So after ethical review, we created 2 secure targeted online questionnaires. One went to consultants and one went to the MERT team providers. They were different questions but targeted the same data, and the results were analysed. So there were no conflicts of interest when I completed this questionnaire, so I actually wasn't participating in the MERT team in any shape or form. And I think that's just important to outline in terms of the results. So the MERT team in our hospital, so we have a team leader who's the Medical Registrar, we have an intensive care senior registrar, we have medical residents, we have surgical residents, and then occasionally we have extras. So we might have an anaesthetic reg, we might have an obstetric reg, we might have an emergency physician. In terms of who we managed to get to fill in the survey, so we actually had really good uptake of this questionnaire without too much encouragement. So people were really interested in the fact that we wanted to know what they had to say, and we managed to get 61 consultants to complete the questionnaire from 13 different specialties, and the numbers are pretty reflective of the size of the specialties in our hospital. And from the actual team itself, we got over 50% of all the people contributing in the team at different levels to give us feedback on their thoughts. So we initially asked people, is this the best system for your acutely deteriorating patients? And despite consultants globally underestimating the number of triggers and thinking there was anything from 2 to 7 triggers per day, only 18% of consultants wanted to maintain the current system that we had. So within hours, pretty much both groups, and pretty much similar percentages of both groups, felt that this was the best system that we were offering our patients. But when it comes to the out-of-hours space, immediately both groups were less satisfied with the care that the patients were receiving. So 82% of the consultants felt the care was inadequate and that more senior input was required. And of those attending MERTs, 56% of them identified concerns that other patients in the hospital's care was being compromised by the MERT system. We looked at whether the team was well trained and well prepared. So initially in our institution, I think people used to get 4 days of training, which then got reduced to 1 day of training, and now the MERT teams that are, and particularly the medical registrars, are given a 45-minute group lecture in being prepared to run MERTs. I looked at, what experience did these people actually have before they were doing MERTs, because I thought that was quite important in terms of what education we were providing them. And I was actually quite surprised with the results, which was that over 50% of those that we surveyed were PGY3 or less. And some of these were acting as the team leader, as the medical registrar. Of the 11% that had more than 10 years of clinical experience, 5 of them were actually intensive care senior registrars, but they weren't team leading the scenarios. And even though there were some very experienced people, 84% of all the team members attending MERTs felt inadequately prepared for what they were going to find when their pager went off. So I thought maybe people wanted more clinical training, but in fact the answer was that they actually want more non-clinical training. So they want to be taught how to do advanced healthcare planning, so when they're called in the middle of the night to see these patients, they know what to do. They want to be taught where to go in the hospital instead of a pager which says some physio gym, but actually there's 7 physio gyms, so which one are they meant to go to? And they wanted to know how to communicate with each other better and with their consultants. The other issue that we highlighted through this study was that actually ALS training wasn't mandatory for those who were attending MERTs. And over 44% of those attending, which included the medical registrars, had no formal ALS certification or training. And so this was quite important information that we could take back to the management to implement change. So in terms of role definition, so it's hard to lead a cavalry charge if you think you look funny on a horse. And I think that's really important, because if people don't feel comfortable in the role that they've been allocated, they're actually not going to be very good at it. And what this survey really showed was that a lot of people weren't comfortable with what they were doing, and people didn't know what they were meant to be doing to begin with. So we've asked people, who's the team leader? Is it the medical registrar? And only 2/3 of people attending MERTs identified the medical registrar as their team leader. Was it the ICUSR? So 27% of people wanted the ICUSR to be the team leader, including one MedReg, which I thought was quite interesting. And 17% of people were identifying the ICUSR as the team leader. So there was also some power imbalances around the bed space and some confusion. And so did that in itself lead to communication issues around the patients and around speaking to each other? And I think communication is a massive problem. So we all get taught how to deal with the problem patient, the problem relative, and then the extreme scenario of a colleague who's, intoxicated or some other crisis. But we don't actually get taught how to communicate and play well with each other as a group. And I really think that, that needs systematic change from an early stage. So we asked people, do you see conflict at the bed space? And I think it's pretty disturbing that in every scenario people have identified conflict at the bed space when they've been involved in these scenarios, specifically between doctors. But also, quite worryingly, 1/3 of people have noticed conflict with family or relatives, which, is a really bad outcome for everybody. We asked people, if you do see conflict, why is there conflict? And disposition was outstandingly the major outlier in these results. So I think this really falls down to that group of patients who, depending on your facility, either have lacked advanced healthcare planning, and so they're actually in a position that you're changing them to palliative care, but everybody on the ward's lost their nerves and they don't want to continue to look after them on the ward, or it's now perceived to be too complex a problem to look after on the ward. But obviously the intensive care stance is that it's not necessarily appropriate for the patient to come to intensive care just to be palliated. We should be looking to actively treat patients. But again, this result highlights an issue with communication. And I thought what was interesting in these figures was that actually 45% of people highlighted that contacting a consultant remotely actually increased conflict at the bed space rather than resolved conflict at the bed space. And I think that's something that, is really important. And the other factor, which I'll go back to at the end, is the individual factors and personal factors, which I'm quite concerned that as a group of junior doctors, we don't always identify our own deficiencies as contributing to some of these conflicts. So we asked people, what happens if you need to contact a consultant after hours about these patients? So the consultants say they're not being called and that they want to be called. But 100% of trainees in this study, 100% reported barriers to contacting their consultants. So there were multiple reasons for that, as you can see. And obviously time constraints and multiple MERTs was highlighted as the #1 reason. But my suspicion would be, and my concern would be, that some of these other more lower ranked reasons, such as perception of colleagues and fear of response, are playing a part. And as you can see, making contact out of hours was considered significantly more difficult than making contact in hours. So why is that? Is that because people don't want to call? Or is that because people don't want to take the call? So the consultants are saying they want to be called, and people are saying they can't call them. And I think that this is a very complex scenario, and in not just our institution, probably in many. So in terms of actually at the coalface, we asked people, do you feel that individual factors play a role in your performance? We said, do you find that you have ever been impaired in your decision making by any of the following? And 97% reported impaired decision making secondary to personal factors, poor roster, lack of clinical experience, and lack of senior support. But only 30% of these in the previous questionnaire attributed personal factors as being contributory to communication breakdown and communication issues. And I think that this is something that we really need to look hard at ourselves as junior doctors. Is the problem at our level, or is the problem above? And it's probably multifactorial and at both. But if you don't identify your own predisposition to poor communication, you're probably not going to achieve great communication. We also looked at advanced healthcare planning, and I'm pretty sure all of us have felt like the chicken who's been to a MERT call realizing that the stable door is closed and the horse is bolted, and you're left with a very sick patient who has no advanced healthcare planning. So had people had the discussion, and so we'd ask the consultants, do you feel that your documentation is adequate if your patient clinically deteriorates and has a MERT for advanced healthcare planning? And I was expecting most people to say that their documentation was excellent. But people were surprisingly candid and honest, and gave the feedback that 91% of them thought that over half the time their team hadn't put in the notes adequate provision for advanced healthcare planning or had the discussion that they needed to have, which I felt was a really positive thing, because it really did bring it back to them that it was important that they, instructed their team to do what they should do with the patients that they know, with the pathology that they understand. When there was unresolved advanced healthcare planning issues, not only was it a trigger for MERTs, but also it was more a trigger for recurrent MERTs than the primary MERT. And secondly, it actually in itself resulted in communication difficulties in over 52% of cases. And we looked at the bedside implication of that for these trainees who were attending. So 78% of them said that even when there was documentation in the notes, they actually couldn't find it. And 67% of them said, where we can't find it and we don't know what to do, we need more training. Some of them don't even make those decisions within their own medical teams in office hours where they're supported, let alone going to a patient they know nothing about and having to make decisions about end-of-life planning in the middle of the night when they are tired, fatigued, and the nurses around them are fraught. So, it has a huge impact on disposition and workload if we don't sort out advanced healthcare planning appropriately. So in conclusion, could we provide a better service in our hospital? And the answer was overwhelmingly yes, we could. Junior doctors are overall inexperienced, they're anxious, they want and they need more training. Personal factors are impacting on their performance. There are complex barriers to escalation, and treating teams do need to have early discussions and appropriate plans for clinical deterioration and end-of-life care. In terms of were the results of this survey useful, so this survey was presented at Grand Rounds. It was also presented to multiple committees, so safety and quality, quality improvement, our rapid response and clinical deterioration committee, and also I ended up having some meetings directly with executive. And the advantages of actually highlighting what everybody felt but no one had been able to say was that we, for the first time, actually managed to secure funding for mandatory ALS training for registrars, which previously had never happened in our institution. We also got funding and support to develop a new medical education program for wall calls, where we specifically target triggers of patients and concerns, so hypotension, tachypnea, tachycardia. We also use the information to put forward a business case to commence a new senior clinician after hours service at the hospital, which has now been up and running for nearly 6 months. And we also are now looking at options of mandatory notification of consultants for patients who trigger a MERTs to try and negate this issue of vertical communication. And the plan from here, so we're going to repeat the survey in the next 2 months to see if our new Up Late initiative has actually improved clinician satisfaction and improved patient care. And the second thing we're going to do is we're going to roll out our survey hopefully to 2 other big hospitals in our health service and see whether they have the same issues and whether we can add some value in that respect and whether their issues are the same as our issues. Thank you.